Welcome to the Deep Dive, where we take your sources and unpack them to find the most important insights. Today we're diving into a set of revision notes focused on a really critical topic in healthcare. Miscarriage, also known clinically as spontaneous abortion. Our mission is to dig into these notes and pull out the absolute highest yield information, helping you get a clear and actionable grasp of this complex condition.
That's right. We've got a concise document here covering, everything from the fundamental definitions right through to management approaches. It's a topic that carries significant clinical importance and, well, emotional weight too, so having a solid understanding of the core information is truly essential.
Okay, let's unpack this then. We're going to follow the structure of these notes, starting right at the beginning with how this condition is defined and categorized. So according to these notes, how exactly is a miscarriage defined?
Okay, so this source defines it as the loss of pregnancy before viability. The typical cutoff points provided are less than 20 months gestation or a fetal weight under 500 grams. The notes do clarify that while pregnancy loss can be medically induced, our focus here, based on these notes, is specifically on spontaneous loss.
Right, the natural loss.
Yeah.
And I notice in the notes, there isn't just one way this happens, is there? They list several distinct types of spontaneous miscarriage. Could you walk us through those and maybe highlight what makes each one different?
Absolutely. The notes outline 7 types, and yeah, understanding the differences is really key for clinical assessment. So first up, threatened miscarriage. This is characterized by painless vaginal bleeding happening before PEM 4 weeks, often quite early, maybe between 6 and 9 weeks. The bleeding is typically lighter than a menstrual period, and a crucial point here, really crucial, is that the cervical os, that's the opening of the cervix, is closed.
Awesome.
Then there's miscarriage, sometimes called delayed. This is when the fetus has unfortunately passed away within the gestational sac, but the body hasn't expelled it yet, usually before 20 weeks. The symptoms here can be subtle, maybe some light bleeding or a dark discharge. Pregnancy symptoms like nausea might vanish, and importantly, again, the cervical os remains closed. The notes later mention a presentation where there's a retained deceased fetus, a uterus that feels smaller than expected for dates, dark discharge, and a still positive pregnancy test that really fits into this category of the pregnancy not progressing but also not being expelled.
Okay, still closed Oz there too.
Exactly. Now, inevitable miscarriage is next. As the name sort of suggests, this process is underway and it can't be stopped. It presents with heavy bleeding, often with clots, significant pain, and the key differentiator here is that the cervical os is open.
Open, so that's the big change.
That's the signal it's progressing. Then, incomplete miscarriage means some, but not all, of the pregnancy tissue has been expelled. Patients will have ongoing pain and bleeding, and again, the cervical os will be open. Still open.
Still open. Then there's complete miscarriage. This is when all the pregnancy tissue has been expelled after we knew there was a pregnancy inside the uterus. There might have been heavy bleeding, but an ultrasound confirms no tissue remains. The cervical os is typically open or maybe starting to close.
Okay, so everything's passed.
Right. And finally, recurrent miscarriage, which the notes specifically define as experiencing 3 or more consecutive miscarriages.
That distinction, based on whether the os is open or closed and whether tissue is present or absent, it sounds absolutely fundamental for diagnosis and figuring out what to do next, doesn't it?
It really is. It guides the whole clinical approach.
Okay, moving on then. These notes dive into why miscarriages happen. What do they tell us about the causes, the etiology?
Well, the notes list quite a wide range of potential causes, but they make pretty clear that the most frequent cause, by far actually, is chromosomal abnormalities in the developing fetus.
So something wrong with the genetics early on. Exactly, that's the major factor. Beyond that, they point to maternal factors. Things like issues with the structure of the uterus itself, hormonal imbalances, certain infections, autoimmune conditions like lupus, or perhaps poorly controlled medical conditions like diabetes or thyroid disease and also antiphospholipid syndrome. Other factors mentioned include lifestyle influences, problems with the placenta developing, multiple pregnancies like twins, certain specific genetic translocations in the parents, and an incompetent cervix, which is more often a cause in the second trimester.
Wow, that's quite a comprehensive list, covering both fetal and maternal sides. It seems like some of those causes naturally lead into what the notes identify as risk factors, right?
Exactly. There's a lot of overlap. The risk factors are essentially characteristics that increase the likelihood of those causes actually resulting in a miscarriage. The notes list things like advanced maternal age. That's a really significant one.
Older mothers, yeah.
A previous history of miscarriage, those existing medical conditions we just talked about, Lifestyle choices like smoking, alcohol or drug use, certain infections, a low pre-pregnancy BMI, even paternal age over 45 is mentioned.
Oh, interesting. Paternal age, too.
Yes, and fertility problems, previous uterine surgery or known abnormalities, uncontrolled diabetes again, and yes, stress or significant traumatic events are included too.
It's fascinating they include stress and paternal age. Are there any factors the notes list as being protective? Things that might lower the risk?
They do mention a couple.
Yeah.
Having had a previous successful live birth is noted as protective. Also, experiencing nausea during the pregnancy, believe it or not, and maintaining a healthy diet are mentioned as factors that might lower the risk somewhat.
Right. Okay, so understanding the causes tells us the biological reasons it might happen, and the risk factors highlight who might be more susceptible based on all these different influences. This feels like we're building the picture.
Yeah, and if we connect this to the sort of the bigger picture, let's talk about the pathophysiology. That's the how, the actual mechanism by which these causes lead to the miscarriage. The notes explain that it's varied, naturally, depending on the specific underlying issue, but ultimately it involves some kind of disruption in the normal development of the embryo or fetus, or maybe problems with how it implants or how the placenta functions. These disruptions are triggered by those things we mentioned, the chromosomal errors, genetic issues, hormonal problems, maternal health conditions, infections, or immune reactions. This disruption then leads to the cascade of events that unfortunately terminates the pregnancy and, in some types, results in the expulsion of the tissue.
Got it. So the why and the who lead to the biological how. Now, super important point. If someone presents with symptoms like bleeding in early pregnancy, it's not always a miscarriage, is it?
Right.
What else could it be? What differential diagnoses do these notes say are crucial to consider?
This is a really important question. Because early pregnancy bleeding is a common symptom for several different conditions, some of which are serious emergencies. The notes provide a list of differential diagnoses that absolutely must be considered and ruled out. Top of the list really is ectopic pregnancy. This is a medical emergency where the pregnancy implants outside the uterus, usually in the fallopian tube. Needs urgent attention.
Okay, number one to rule out.
Definitely. Then there's implantation bleed. This is actually normal, just light spotting that can happen when the embryo implants in the uterine wall, often around the time a period might have been due.
So that's benign.
Totally benign. Other possibilities could be coming from the cervix or vagina itself, things like a cervical polyp, that's a benign growth, cervical ectropion, which is where the inner cervical lining kind of extends outwards, or infections like cervicitis or vaginitis. They also list neoplasia, meaning cancerous or precancerous growths, although that's less common in this context. And importantly, hydatiform mole, also known as a molar pregnancy. This is an abnormal growth in the uterus that comes from placental tissue.
Molar pregnancy, right.
So yeah, the key takeaway here is that any bleeding in early pregnancy needs a really careful assessment to distinguish between all these possibilities and get the right diagnosis, because the management can be very different and sometimes very urgent.
Okay, let's step back for a second and look at the scale of the epidemiology. What do the numbers in these notes tell us about how common miscarriage actually is?
The statistics provided are quite striking, really. The notes highlight that miscarriage is, unfortunately, a very common complication of early pregnancy. Using UK data, it's estimated to affect about 1 in 4 pregnancies.
Wow, 1 in 4.
Yeah, it's significant. And that translates to around 50,000 hospital admissions each year in the UK related to miscarriage.
That's a huge number. It really underlines how prevalent this experience is.
It absolutely does. And what's fascinating, as these notes detail, is how that risk changes quite dramatically as the pregnancy progresses. They give specific percentages. The risk is noted as 9.4% at 6 weeks gestation, dropping quite a bit to 4.2% at 7 weeks, then 1.5% at 8 weeks.
A big drop.
A huge drop. And then significantly lower, around 0.5% by 9 weeks, maybe slightly up to 0.7% at 10 weeks. This vividly illustrates that the vast majority of miscarriages happen in those very early weeks. The risk declines sharply once you get a bit further along, especially once a heartbeat is seen later in the first trimester.
That specific week-by-week breakdown is a really high-yield detail from this source, isn't it? It shows that early pregnancy truly is the most vulnerable time. Shifting gears slightly, what does miscarriage typically look like clinically? What are the signs and symptoms mentioned in these notes?
Okay, so the primary clinical presentation described involves vaginal bleeding. This can vary hugely, anything from light spotting to really heavy bleeding, maybe comparable to or even heavier than a period.
Bleeding is key.
Bleeding is key. And accompanying this is often abdominal pain or cramping. Again, this can range from mild, sort of period-like aches to quite severe cramping pain. Patients might also notice passing tissue or blood clots. And a specific sign noted particularly for miscarriages is a decrease or disappearance of early pregnancy symptoms. Things like nausea or breast tenderness might just fade away. Interestingly, the notes also add that if someone has early bleeding but is still vomiting, that actually reduces the risk of miscarriage somewhat, down to about 30%.
Huh, that's an interesting observation. So
Yeah.
it's not just bleeding. Pain and changes in those early pregnancy symptoms are important clues too. And the notes give some practical pointers for examining someone presenting like this.
Yes, these are really crucial steps when you're evaluating first trimester bleeding, as detailed in the notes. First, you need to quickly assess if the patient shows signs of shock from blood loss. Are they pale, clammy, tachycardic? If so, a pelvic and speculum exam needs to happen urgently.
Right, assess stability first.
Absolutely. Then, during the exam, specifically look for any products of conception visible in the cervical canal. If you see tissue there, the notes mention removing it, often using sponge forceps. Crucially, you need to determine if the cervical os is open and closed. And the notes have a useful reminder here. In women who've had previous pregnancies, the external part of the os might naturally be slightly open or admit a fingertip, so you're really assessing the internal os status too.
Okay, the internal os.
Yes. Then you need to rule out bleeding sources other than the uterus, like looking for any lesions on the cervix itself that might be bleeding. And finally, you assess if the size of the uterus feels appropriate for the stage of pregnancy. The patient reports based on their last period or dating scan.
Those sound like really vital, practical steps for a thorough assessment when faced with this kind of presentation. Okay, so we understand the types, the causes, who's at risk, and what it looks like. How do we actually confirm what's happening? What do these notes say are the key investigations?
Right. The notes state that diagnosis relies on a combination of that clinical assessment we just discussed, imaging and laboratory tests. The absolute go-to imaging modality is ultrasound. Specifically, a transvaginal ultrasound is preferred because it gives a much clearer view, especially early on.
Right, the internal view is better.
Much better. It helps locate the pregnancy, look for a fetal pole that's the early embryo, and crucially, assess for a fetal heartbeat. A transabdominal ultrasound over the belly can be used, but its limitations, especially in early pregnancy or with certain body types, need to be explained to the patient.
Okay, so ultrasound gives us the picture. What about blood tests? What do the notes highlight there?
Serial HCG measurements are highlighted as crucial. Human chorionic gonadotropin. The notes are very specific here. They recommend taking 2 serum HCG samples approximately 48 hours apart.
Okay, 48 hours.
Exactly. And this is where the precision comes in. They state that an increase of over 63% over those 48 hours strongly suggests a viable developing intruder in pregnancy.
Over 63% increase, viable.
Correct. Conversely, a decrease of over 50% indicates that the pregnancy is unlikely to continue. A failing pregnancy.
Over 50% drop, likely failing.
Yes. And if the change is in that gray area, a decrease less than 50%, or an increase less than 63%, the notes advise urgent clinical review, usually within 24 hours, because the picture is unclear. That specific timing and percentage change is presented as a very high-yield piece of information to remember.
That detailed guidance on interpreting the HCG changes is incredibly specific and really actionable, isn't it? What else about investigation stood out in the notes?
A couple of other important points. They emphasize that gestational age determination should prioritize ultrasound measurements over calculating just from the last menstrual period, because cycle variability can make the LMP date quite inaccurate.
Ultrasound is more reliable for dating.
Generally, yes, especially if there's a discrepancy. They also stress the importance of careful follow-up for uncertain cases or situations where the pregnancy location isn't confirmed initially, what's called a pregnancy of unknown location or PUL. This means repeat HCG measurements and potentially repeat ultrasound scans until a definitive diagnosis is made. And importantly, they explicitly state that serum progesterone measurements should not be used for diagnosis in the context of a pregnancy of unknown location. They just aren't reliable enough for that purpose, according to these notes.
No progesterone for POL diagnosis. Got it.
Right. And there's also a brief cautionary note just to be aware of rare conditions that can cause elevated HCG levels but aren't typical pregnancies, like gestational trophoblastic disease or certain rare tumors.
Right. So once a miscarriage is diagnosed, what are the different management pathways outlined in these notes? What are the options?
Okay, so the notes describe 3 main approaches. The choice often depends on the type of miscarriage, how far along the pregnancy was, the patient's symptoms, and crucially, involving the patient in the decision where possible patient preference is key. First option is expectant management. This is essentially a wait-and-see approach, waiting for the miscarriage to complete naturally without intervention. The notes suggest allowing maybe 7 to 14 days for this. If it hasn't fully resolved by then other options are usually considered.
Okay, so waiting first.
That's one option. Next is medical management. This involves using medication to help the body expel the remaining pregnancy tissue. The notes specifically name vaginal misoprostol. Misoprostol is a prostaglandin analog, so it basically causes the uterus to contract and expel the contents. An interesting point of contrast the notes make is that while vaginal misoprostol is used, oral mifepristone is not recommended for medical management in the UK guidelines they seem to be referencing, which is different from practices elsewhere, like in the US.
Ah, okay, a UK-specific point, perhaps.
Seems so. And with medical management, supportive care like anti-sickness medication, antiemetics, and good pain relief is provided. Patients are typically told to seek medical help if significant bleeding hasn't started within about 24 hours after taking the medication. The third approach is surgical management. This is a procedure to physically remove the pregnancy tissue from the uterus. This can be done via manual vacuum aspiration, MVA, which is often performed in an outpatient clinic setting under local anesthesia. Or it can be surgical management in theater, SMT, usually under general anesthesia, often for removing retained products of conception after an incomplete miscarriage, or if medical management fails or isn't suitable.
Okay, so expectant, medical with misoprostol, or surgical. Clear options, allowing for a tailored approach, hopefully. Is there anything else critical included in the management section of these notes?
Yes, there's very specific guidance on anti-D rhesus prophylaxis, anti-D immunoglobulin. The notes state this should be offered to all rhesus-negative women if they undergo surgical management for either an ectopic pregnancy or a miscarriage.
Only surgical.
For miscarriage, yes, specifically surgical management according to these notes. It is explicitly not recommended for women undergoing medical management for miscarriage, or for those with threatened miscarriages, complete miscarriages where everything has passed, or pregnancies of unknown location. That's a very precise distinction to remember regarding who needs anti-D.
Okay, that's a key detail.
The notes also briefly touch on prevention, but it's mainly focused on promoting general healthy lifestyle factors, things like reducing alcohol intake, quitting smoking, avoiding illicit drugs. They do note that while vitamin supplementation generally doesn't prevent miscarriage itself, taking multivitamins that contain iron and folic acid is associated with a reduced risk of stillbirth later in pregnancy.
Right. Looking beyond the immediate event then, what do these notes say about the prognosis, the likely outlook for someone after they've experienced a miscarriage?
Generally, the notes describe the prognosis as quite favorable for having a successful subsequent pregnancy, particularly after experiencing just one miscarriage. Most people go on to have healthy pregnancies. However, they do note one specific link. A threatened miscarriage, even if the pregnancy continues, is associated with an increased risk of preterm delivery in future pregnancies.
Boarding.
Yeah. And as we touched on with the definitions, having had multiple miscarriages, unfortunately, does increase the risk of having future ones. That's the definition of recurrent spontaneous miscarriage. But importantly, the notes also offer some reassurance that miscarriage-related deaths, maternal deaths, are very rare.
Okay, generally positive outlook, but with that note about preterm risk after threatened miscarriage, and the issue of recurrence. And finally, what about potential complications? What downsides or risks might someone face?
The notes list several important complications to be aware of. Firstly, excessive bleeding or hemorrhage. This is a particular risk with incomplete miscarriages where tissue might be retained in the uterus.
Makes sense.
Secondly, infection. This is also a risk if tissue is not fully expelled, potentially leading to endometritis or pelvic inflammatory disease. And very importantly, the notes highlight the potential for significant emotional distress. This affects both the individual who experienced the miscarriage and often their partner too. The psychological impact can be profound and shouldn't be underestimated. They also sort of reiterate that incomplete miscarriage itself, because of that retained tissue, is considered a complication because it causes ongoing bleeding and cramps, and often necessitates further intervention, usually surgical.
Right, the emotional toll is a really crucial point to include. Okay, well, we've really done a deep dive into these revision notes on miscarriage today. We've covered everything from how it's defined and the different ways it presents, through the causes and risk factors, the underlying mechanisms, what else it could be, the numbers, the clinical picture, how we investigate, the management options, the prognosis, and those potential complications.
Yeah, unpacking the source has really highlighted the necessity of careful clinical assessment, the specific value of tools like transvaginal ultrasound and that precise serial HCG monitoring we discussed, and also the importance of offering appropriate evidence-based management options that include patient preference. Understanding these points from the notes provides a really solid foundation, I think, for anyone needing to be well informed on this topic.
It certainly shows the complexity beneath what might seem, maybe from the outside, like a single event. The level of detail these notes provide for revision is pretty impressive. Considering everything we've covered from these notes, what stands out to you as perhaps the most impactful or maybe even challenging piece of information?
That's a good question. I think for me, it's the combination of that sheer frequency, that 1 in 4 statistic is just sobering, alongside all the detailed clinical information, and then having that explicit mention of significant emotional distress listed right there as a key complication. It really underscores that while we break this down into clinical pathways and percentages for learning and management, the human experience behind those facts is absolutely central and must be acknowledged.
Absolutely. I couldn't agree more. It really reinforces that mastering the clinical detail from sources like these ultimately allows for better, more compassionate care, encompassing both the physical management and acknowledging those emotional aspects that the notes rightly highlight. Well, thanks for joining us for this deep dive. Keep exploring, keep questioning, and keep learning.